Grief and loss, how to assess and intervene. The American Psychological Association defines a difference between mourning and bereavement. Mourning is the process of feeling or expressing grief following the death of a loved one, or the period during which this occurs, as opposed to bereavement, which is the condition of having lost a loved one to death. Grief, however, is described as the anguish experienced after the significant loss, usually the death of a beloved person. There are a variety of forms of grief: normal grief, complicated grief, traumatic grief, anticipatory grief, disenfranchised grief, distorted grief, exaggerated grief, masked grief, inhibited grief, collective grief, cumulative grief, prolonged grief, abbreviated grief, delayed grief, and absent grief. Acute grief is considered normal, uncomplicated grief and is experienced as neither linear nor experienced in similar ways. Normally, this is associated with death bereavement, but can occur in response to adverse life events and losses. Symptoms of acute normal grief include yearning for and seeking proximity to the deceased, loneliness, crying, sadness, and other painful emotions like anger, guilt, and anxiety, somatic symptoms like physical sensations, disrupted sleep or appetite, insistent thoughts, memories of loss may include hallucinations, and feelings drawn to things that remind the individual of the deceased person, as well as social withdrawal and disinterest, identity confusion, disbelief and shock, numbness, impaired attention, concentration, or memory. When looking at grief, we must consider the stage of grief according to Kubler-Ross, which are denial, anger, bargaining, depression, and acceptance. There are 4 tasks associated with mourning, according to J.W. Warden: to accept the reality of the loss, to work through the pain of grief, to adjust to life without the deceased, and to maintain a connection to the deceased while moving on with life. We must also know that there is a typical course of acute grief. This lasts about 6 to 12 months and is considered time-limited when evaluating potential clinical diagnoses. Differently, complicated grief is a persistent form of intense grief in which maladaptive thoughts and dysfunctional behaviors are present along with continued yearning, longing, and sadness and/or preoccupation with thoughts and memories of the person who died. It should be noted that there are risk factors for complicated grief. This includes having an insecure attachment style, age, sex, or socioeconomic status, prior psychiatric history, and circumstance of the event or death. Complicated grief typically has unique features, such as maladaptive rumination, increased somatic symptoms, dysfunctional behavior, impaired function such as distrust in others, lack of concentration, and inability to engage in daily activities. When considering whether someone qualifies as having a clinical diagnosis of persistent complex bereavement disorder, or PCBD, one must consider the following diagnostic criteria. The patient experienced the death of a loved one at least 6 months previously. At least one of the following symptoms has been present longer than expected, taking into account the person's social or cultural environment. Intense and persistent yearning for the deceased, frequent preoccupation with the deceased, intense feelings of emptiness or loneliness, recurrent thoughts that life is meaningless or unfair without the deceased, and a frequent urge to join the deceased in death. At least 2 of the following symptoms have been recorded for at least 1 month: feeling shocked, stunned, or numb since a loved one's death, feelings of disbelief or inability to accept the loss, rumination about the circumstances or consequences of the death, anger or bitterness about the death, experiencing pain that the deceased suffered, or hearing or seeing the deceased, trouble trusting or caring about others, intense reactions to memories of or reminders of the deceased, avoidance of reminders of the deceased, or the opposite, seeking out reminders to feel close to the deceased. Symptoms can cause substantial distress for the sufferer or impact significantly on areas of functioning and cannot be attributed to other causes. It is important to consider differential diagnosis as well, which could include normal or typical grief, depressive disorders, post-traumatic stress disorders, and separation anxiety disorders. When assessing a patient or client for potential complex grief, you would consider, first of all, the history of the presenting illness, such as intensity, presence and symptoms, relationship to the deceased, circumstances of the death, subsequent grief symptoms, complicating features, Suicidal ideation and behavior should always be assessed. Factors that exacerbate or lessen the grief symptoms. Impact of symptoms on occupation and interpersonal functioning, including social support and engagement. Presence of comorbid psychopathology like depression, anxiety, PTSD, and substance use. Second, you would look at social history. Presence of other stressors, other than the death, what made them seek out help, level of social isolation, and sources of support. And then you would look at family history of mental health factors, as well as conduct a mental status exam, looking at cognition, speech, affect, psychomotor activities, and rumination. General medical history should also be considered, as well as physical exam results and lab tests that are applicable. In looking at interventions, it would depend on the type of grief. Acute grief typically does not require treatment. It is usually resolved through support of family, friends, and clergy. Complicated grief requires education, and the individual should be seen every 1 to 4 weeks, depending on severity. It is noted that clinicians working with someone with complicated grief can facilitate adaptive coping in 2 ways. First, aid the patient in thinking about the loss of a loved one in a more peaceful and acceptable way. And 2, discuss restoration of a satisfying life without the deceased.